A very good morning to all. Today our topic will be on urinary tract infection in children. Before going into the topic proper, first we will see some case scenarios regarding urinary tract infection. First, an 8-month-old male child presented with fever for 5 days to a general practitioner. So, the urine culture grew Escherichia coli more than 10 to the power of 5 colony forming units per ml. The child was treated with injection cefotaxime for 10 days, but no further evaluation was done. Is this treatment done for this child was correct or not? We will be discussing in the further slides. Is it important to evaluate the child further? Those things also I will be discussing in the further slides. So why is the diagnosis of a UTI is very important in children? First, what is the definition of UTI? We will know. Urinary tract infection is defined as culture positivity in the presence of symptoms. Urine culture has to be positive, and at the same time, child should have symptoms. Both of the things should be present to diagnose the child with urinary tract infection. So UTI may bring to attention a child with an obstructive anomaly or severe vesicuratory reflex. These are the things which are very important because the diagnosis of UTI brings the child with an obstructive anomaly or severe vesicuratory reflex to the general practitioner. If there is a delay in diagnosis of a UTI, the child may go into septicemia or scarring. UTI is also one of the risk factors for acute kidney injury. UTI in young infants can also lead to failure to thrive. And there are some long-term complications of UTI, which will be renal scarring. Because of renal scarring and activation of the renin-angiotensin system, there will be hypertension, and then there will be also chronic renal failure. So these are the things which are very important in the aspect diagnosis of UTI leads to these of the things. Leads to prevention of these of things, like diagnosis of a UTI, early diagnosis of a UTI leads to prevention of these of the things. So before going into urinary tract infection diagnosis and treatment, first we will see clinical features in neonates, infants, and older children. So in neonates, the symptoms will be like lethargy, refusal to feed, neonatal the infant can also present as a neonatal cholestasis. Child can also present with the hypothermia or hyperpyrexia. There can be features of septicemia. This is why early diagnosis of UTI is very important. If delay in diagnosis of UTI happens, there will be that can lead to features of septicemia. So in infants, there can be unexplained fever, persistent diarrhea, and vomiting. In older children, there can be burning micturition, crying during micturition, fever, flank pain, urgency, and frequency. So we will be seeing some more case scenarios. First case scenario, a 2-year-old girl presents with fever with crying during micturition. There are 8 pus cells per high power field on a centrifuge urine specimen. Is this significant? So the kid is having fever with crying during micturition. So symptoms are there. On centrifuge urine specimen, there are 8 pus cells. So if this is this significant, it means urine samples can be divided into centrifuge urine sample and uncentrifuged urine sample. The pus cells per high power field on a centrifuged urine sample in the diagnosis of UTI differs from that of a non-centrifuge or uncentrifuged urine sample. So we will be discussing about things in the later slides. But this kid 8% in a centrifuge urine specimen is significant. So we have to send urine culture in this child and then we have to start antibiotics. A 7-year-old boy presents with the previous case. As of now, we can't diagnose the child as urinary tract infection because urine culture now only we are sending. If the urine culture comes positive only, then we can diagnose the child as urinary tract infection. Till now, we have got symptoms, and at the same time, pustules are there in urine sample. So it is significant. So we have to send urine culture for this child. A 7-year-old, and then we have to start antibiotics. A 7-year-old boy presents with fever and cloudy urine. On examination, he has fever 39.5°F with renal angle tenderness. As per the ISPN, means Indian Society of Pediatric Nephrology terminology, what is the diagnosis? So here, child is having fever and cloudy urine. On examination, child is having fever 39.5° and renal angle tenderness. Child is having very high grade fevers, and then also renal angle tenderness is present. So here we have to send urine culture. If at all urine culture comes positive, then this child will come under complicated UTI. Complications of UTI we will be discussing in the further slides. So the parent of a 4-year-old girl are worried about a urine culture report growing E. coli 10⁴ colony forming units per ml. She is asymptomatic, no fever, dysuria, flank pain, urgency, constipation, etc. No dehydration also, the child is very active. Here, first of all, child is not having any symptoms. And then the urine culture which grew E. coli also, it has very less colony forming units per ml. For a midstream collected urine sample, the colony forming units has to be more than 10⁵ colony forming units per ml. That is very significant. Here it is only 10⁴. So urine culture which grew E. coli also, it's not significant, and this child is also not having symptoms. So this child won't come under the diagnosis of urinary tract infection. So some terminologies we have to know before going into the diagnosis and treatment. So significant pyuria is defined as 10 leukocytes per millimeter cube in a fresh uncentrifuged sample. This we have to know. Like in an uncentrifuged sample, it is more than 10 leukocytes per mm per cube. Whereas in a centrifuge sample, it is 5 leukocytes per hyperfill. So going to the previous slide, the first case you have seen 8% on a centrifuged urine sample. So it is significant. In a centrifuged urine sample, if a child is having more than 5 pustules per hyperfill, then it is significant. So first case, the child is pustules in hyperfill is significant. So we have to send culture and start antibiotics. So some of the terminologies are significant bacteriuria. So here colony forming unit, this significant bacteriuria we are defining in a midstream clean catch sample. Please note that it is a midstream clean catch sample, because in other methods of sample collection, we will be discussing how much colony count is significant. So in the further slides, we'll be discussing over that. But this significant bacteriuria is for a midstream clean catch sample. Colony forming unit should be more than 10⁵ per ml. So asymptomatic bacteria is significant bacteria in the absence of symptoms of UTI. This is what I'm telling. If a child is having bacteriuria, but child is not having any symptoms of UTI, then we have to label the child as asymptomatic bacteria, not UTI. So simple UTI. Simple UTI is with low-grade fever, dysuria, frequency, urgency, and absence of symptoms of complicated UTI. So what are the symptoms of complicated UTI? We have to know. Complicated UTI, there will be signs and symptoms and laboratory signs of pyelonephritis. So that is what presence of fever more than 39°C, systemic toxicity, persistent vomiting, dehydration, renal angle tenderness, and raised creatinine. So recurrent infection means second episode of UTI itself is a recurrent infection. So these are some of the terminologies which you have to know. These terminologies have been given in International Society of Pediatric Nephrology Consensus Statement 2011 September. So this is a urinalysis sample showing leukocytes in a high power field, and you can also see a strip which has leukocyte esterase nitrite This first two are very important, the diagnosis of UTI, like leukocyte esterase and nitrite. We will be discussing about the sensitivity and specificity of these tests in the further slides. So urine collection analysis. So urine culture has to be sent for confirmation and therapy, because if the urine culture grows the organism only, then we can diagnose a child as UTI. And then we have to, based on the culture and based on the antibiotic susceptibility, we have to decide upon the therapy. So toilet trained children, we have to collect a midstream urine sample. Whereas in infants, a catheterized sample or a suprapubic aspiration has to be done. So in a urinalysis, more than or equal to 5 WBCs per hyperfill on a centrifuge urine. On a centrifuge urine is significant of UTI. And then other dipstick tests which can be done, which can aid in the diagnosis of UTI are nitrite and leukocyte tests. So here we can see the sensitivity and specificity of components of the urinalysis, which is given by the American Academy of Pediatrics. You can see the leukocyte esterase as a single test has more sensitivity among the other tests, and nitrate has the more specificity as a single test has more specificity compared to the other tests. So if we combine leukocyte esterase and nitrite, they have more sensitivity and specificity together. So that is the funda. We are doing both leukocyte and esterase. On other tests which are being done are microscopy, which is showing white blood cells and bacteria. These are the sensitivity and specificity for each test. So in our routine practice, we are doing leukocyte esterase and nitrite dipstick. So interpretation of, again, we are insisting on the same point, interpretation of urine culture. So here in suprapubic aspiration, even one pathogen in any number is suggestive of UTI, and the probability of infection is given as 99%. Whereas in a urethral catheterization, more than 50,000 colony forming units per ml is significant, and probability of infection is 95%. Whereas in midstream clean catch urine, you have to have more than 10 to the power of 5 colony forming units per ml, and the probability of infection is 90 to 95%. So initial evaluation which has to be done in these kids. So main first thing in a diagnosis of UTI will be history, with which only kids and the parents come to us. So symptoms needed to establish the diagnosis of UTI. Already I have discussed about the symptoms which we will be able to pick in a neonate, infant and children. So symptoms needed to establish a diagnosis of UTI, and then we have to classify the UTI based on the symptoms. I told you simple UTI will be just urinary symptoms, whereas fever, high-grade fever, systemic toxicity, persistent vomiting, dehydration, then raised creatinine, renal angle tenderness, these and all will come under complicated UTI. Complicated UTI means pyelonephritis. It indirectly signifies pyelonephritis. So antenatal history also we have to take, and then symptoms related to underlying structural anomaly and symptoms related to bowel bladder dysfunction. These symptoms we'll be discussing in the further slides. So examination, it includes vital signs. We have to look for temperature, whether there is a tachycardia, tachypnea. If there is a tachycardia, tachypnea, then it signifies systemic toxicity, and then child can have septicemia also. So we have to look for those things, and degree of toxicity, hydration, temperature and hemodynamic status, oral acceptance, poor urinary stream. Spine, anus and lower limbs are very, very important. These things are, definitely has to be examined in a child, infant or neonate presenting you with urinary tract infection, because spina bifida, neural tube defects, they will have involvement of the lower legs, and then they will have involvement of the urinary system also, and then they will present with recurrent UTI. So you have to be very cautious with the diagnosis, and then you have to examine the spine, anus and lower limbs in all these children, and we have to look for palpable bladder and kidneys also, because in a UTI where they have a structural anomaly, because of this VUR, child can have hydronephrosis, and then there can be palpable bladder. And renal angle tenderness is to look for a complicated UTI, which indirectly signifies pyelonephritis. So features suggesting underlying structural abnormality, these are the things. Here you can see child is having phimosis, then child is having here child is having labial adhesions, here child is having spina bifida, with a myelomeningocele. Here, child is having a skin tag. These are some of the features which are suggestive of neural tube defect, and the child can also have phimosis, and child can have also labial adhesion. So, in examination of a neonate is very important who present with a UTI. So, bowel bladder dysfunction. The primary pathology goes this way only. Bowel bladder dysfunction is means constellation of lower urinary tract symptoms associated with constipation and or encopresis. So here pelvic floor overactivity can lead to dysfunction of the urinary bladder, and there can be urinary incontinence, infection, reflux, and at the same time pelvic floor overactivity can also lead to bowel dysfunction, which ultimately can lead to constipation, encopresis, and soiling. These urinary incontinence, infection, and reflux and constipation, encopresis, and soiling, these two constitutes the bowel bladder dysfunction. So features suggestive of bowel bladder dysfunction can be recurrent urinary tract infections, persistent high-grade vesicoureteral reflux, constipation, impacted stools, maneuvers to postpone voiding. I will be showing some pictures of this holding maneuvers in the further slides. Like that is a very significant holding maneuver which is known as Vincent's curtsy, and there can be squatting episodes also with the pressing of the heel into the perineum to then there can be voiding less than 3 or more than 8 times a day, straining or poor urinary stream, thickened bladder wall more than 2 millimeter, post-void residue more than 20 millimeter, spinning top configuration of bladder on mixture-eating cystiurethogram. These are some of the features which are suggestive of bowel bladder dysfunction. So holding maneuvers, this is the holding maneuver, which is very characteristically known as Vincent's curtsy, and it is one of the this one is holding maneuver which is for male children, and this one is squatting episode with heel pressing into the perineum. These are some of the holding maneuvers which are suggestive of bowel bladder dysfunction leading to recurrent urinary tract infection. And management. So management part, complicated UTI and infants less than 3 months, we have to give parenteral antibiotics. The duration is 10 to 14 days. In simple UTI and kids above 3 months, oral antibiotics is enough for 7 to 10 days. So some case scenarios we will be discussing. A 7-month-old boy is recently diagnosed with febrile UTI due to E. coli. What evaluation should be done during follow-up of this infant as per Indian Society of Pediatric Nephrology guidelines? So here an infant has been diagnosed with UTI. So definitely we'll be doing ultrasound in this kid to look for any signs of hydronephrosis and any signs of pyelonephritis. So further evaluation in this child, if the child is less than 1 year, then definitely we have to do MCU and Dmse once the infection settles. MCU has to be done 2 to 3 weeks. After 2 to 3 weeks of infection, we have to send a urine culture. If a urine culture comes sterile, then we have to do MCU. This MCU is mainly to look for any vesicoureteral reflex is there or not, to rule out these structural abnormalities and then any vesicoureteral reflexes there or not. So after doing MCU, we have to do Dmse also, but Dmse has to be done after 2 to 3 months, because the scarring which develops in the kidney due to this UTI, it at least takes 2 to 3 months to develop. So doing before 2 to 3 months will not yield so much. So ideally, if a child less than 1 year develops UTI, then all 3 investigations has to be done, like ultrasound, mixture-eating cystiurethogram, and Dmse. So here a 2.5-year-old girl, here we have to definitely do ultrasound, and then we have to do Dmse. If Dmse comes abnormal, like if you are able to see renal scars, then we have to go for MCU. No need to do MCU routinely in this kid, 2.5-year-old child, because MCU is an invasive procedure. So if at all we are seeing some signs of we are seeing a renal scar in a Dmse, then we can go for MCU. A 7-year-old girl has recently completed treatment for here. A 7-year-old girl has been diagnosed with simple UTI. Here only ultrasound is enough. If ultrasound is normal, no need to go for MCU or Dmse. If ultrasound is abnormal, then we have to go for MCU and Dmse. So follow. This is what I was telling in the previous slide. So first urinary tract infection, if age is less than 1 year, we have to do all investigation, ultrasound, MCU, and Dmse renal scan. If age is 1 to 5 years, ultrasound Dmse scan is done. If ultrasound or Dmse scan is abnormal, then you have to go for MCU. If age more than 5, ultrasound alone is done. If ultrasound abnormal, then we will go for MCU and Dmse. This is based on International Indian Society of Pediatric Nephrology Consensus Statement 2011 September. So hydronephrosis on ultrasound, there will be a characteristic beer paw appearance, anechoicaria in the hilum of the kidney indicating dilated renal pelvis. This you can see that a beer paw appearance. So VUR grades on MCU. So grade 1 VUR is just a reflex into the non-dilated ureter. Here you can see reflex, but the ureter is not dilated. Grade 2, here also there is reflex into a non-dilated ureter, but the reflex is up to renal pelvis and calyces, everything you can see. But the ureter is still non-dilated. Here the reflex is only into the ureter, but here it's going to renal pelvis and the calyces. Grade 3 means there will be moderate, mild to moderate dilatation of the ureter. Here the dilatation of the ureter starts from grade 3 only. So grade 4, apart from dilatation, there will be tortuosity of the ureter also, and then the dilatation also will be moderate dilatation. Grade 5 will be very severe dilatation with the tortuosity of ureter, and at the same there will be tortuous renal pelvis and then calyces also. So this is a Dmse scan showing renal scarring in the superior pole, which is suggestive of left kidney scar in the superior pole. So timing of Dmse, ultrasound should be done soon after the diagnosis of UTI, whereas MCU is recommended 2 to 3 weeks later. Once you have completed antibiotics, then we have to send a repeat culture. The culture comes sterile only, then we have to do MCU. Then Dmse scan is carried 2 to 3 months after the treatment, because I have already explained you, like a renal scar will take at least 2 to 3 months to develop. So Dmse has to be done after 2 to 3 months. So an early Dmse scan performed soon after UTI is not recommended in routine practice. Patient showing hydronephrosis in the absence of VUR should be evaluated by diuretic renography. Here, if VUR is absent, but child is having severe hydronephrosis, then problem will be in the renal pelvis only. This condition is known as pelviureteric junction obstruction. That condition is mainly picked up by diuretic renography, like DTPA scan. So this is a VUR staging. So grade 1 VUR staging, it happens into a non-dilated ureter. Grade 2 VUR staging into the pelvis and calyces without dilatation. Grade 3, mild to moderate dilatation of the ureter and renal pelvis. Grade 4, moderate dilatation and or tortuosity of the ureter. Grade 5, severe dilatation and tortuosity of ureter, renal pelvis and calyces. So here you can very nicely see the natural history of VUR. Like grade 1 UVUR, the x-axis is years since presentation, y-axis is presentation of the child with reflex. So grade 1 VUR at 0 years of since present, at the time of presentation, as time progresses, the grade 1 VUR resolves. 100 if at the presentation, if it's 100%, after 5 years of presentation, grade 1 VUR, only 10% of the kids are symptomatic, whereas in grade 5 VUR, after 5 years also, nearly 95% of the children are still symptomatic. So this is the funda for giving prophylaxis for more time in grade 5 VUR, whereas prophylaxis for less time is enough for grade 1 VUR. That we'll be discussing in the further slides. So management of a primary VUR, grade 1 and grade 2, antibiotic prophylaxis until 1 year old is enough, because I have shown you, because in natural history of the VUR, grade 1 and grade 2, as time progresses, most of the cases will resolve. So antibiotic prophylaxis for 1 year is enough. Antibiotic prophylaxis until 1 year old, restart antibiotic prophylaxis if breakthrough febrile UTI happens. Whereas in grade 3 and grade 4, antibiotic prophylaxis has to be given up to 5 years of age. Consider surgery if breakthrough febrile UTI occurs. Beyond 5 years of age, prophylaxis continued if there is a bowel bladder dysfunction. This is based on ISBN consensus statement 2011. So there are some causes for whatever we have discussed before is just primary viewer. Primary viewer has many reasons for that, like it is a familial genetic condition, whereas there are some primary viewer familial genetic, or it can be inherited also. Whereas in secondary viewer, there are some causes for secondary viewer like neurogenic bladder, duplication of ureter, PUV, like posterior urethral valves, ureterocele, duplex collecting system. These are some causes for secondary vesicoureter reflex. So investigations after UTI, like comparison of guidelines, we are following ISBN 2011 guidelines. They have given like ultrasound has to be done in all patients, but in NICE 2007 guidelines, what they have given is it has to be routinely done only for infants less than 6 months, whereas in infants more than 6 months, only when atypical or recurrent UTI happens. Whereas in AAP 2011, it has been given all patients you have to do ultrasound. For MCU, recommendations from ISBN 2011 is routinely done for children less than 1 year, or if scarring is present in Dmse, then we have to go for MCU. Whereas in NICE 2007 guidelines, if a child is developing atypical or recurrent UTI in less than 6 months, or if ultrasound is abnormal, then only we have to go for MCU. Never above 3 years, MCU has to be done. Whereas in AAP 2011 guidelines, for children less than 2 years, if abnormal USG is there, then we have to go for MCU. In DMSA, in ISBN 2011 guidelines, it is routinely done for children less than 5 years, whereas in NICE 2007 guidelines, atypical recurrent UTI in less than 3 years, DMSA is done. DMSA recommendation, it's not given in AAP 2011. So key messages, UTI in children should be viewed as a serious infection that has a potential for renal scarring. So UTI should be promptly and effectively treated to avoid long-term morbidities. UTI in children may significant abnormal urinary tract that contributes to ascending infection. So thank you. If any doubts are there, people can ask now. If there are no doubts, I can stop the presentation. I will complete my presentation. Thank you.